So today I'm going to talk a little bit about what nutritional psychiatry is, give a bit of an overview of the research that's been done in this area, and then hand over to Dr. Tetyana Rocks, who leads our Food and Mood Academy. I'm imagining, given the audience at the Equally Well conference, that there's going to be quite a lot of interest in this because it's a very key way in which we can target or improve both mental health and physical health in a way that is highly cost effective and efficacious. So it offers a lot of potential benefits. So Tetyana, if you can move on to the slide, what is nutritional psychiatry? It is primarily the research that investigates how what we eat, our diet and nutrition, influence our mental and brain health across the life course. And then it's the application of this knowledge into clinical practice, into public health, and policies and prevention strategies. But what it's not is integrative medicine, complementary medicine, alternative medicine, functional medicine, all of these sorts of medicines that have a tarnish because they come with the prejudice that they don't tend to have a good evidence base. And what we do at the Food and Mood Centre and in the field more broadly, hopefully, is to really generate very, very high level evidence, like rigorous gold standard scientific evidence. So what we've done so far in the field, which is only just over a decade old, this is the field of nutritional psychiatry, is establish that there's this very clear link between the quality of people's diets and their risk of developing what we call the common mental disorders, so depression and anxiety. And most of the research evidence is focused on depression and the research studies. And the work that we've done has had a big impact on the public knowledge and captured the public interest, I think. And this is, of course, because everybody eats, everyone's interested in diet, and everyone has mental health of one sort or another and a brain. And so this idea of the link between the two has been very a source of great interest to the general public and to the media. And this is really useful because this is something that we want to get across to people, that they need to think a little bit maybe about what they put in their mouths and also give them their own strategies for maybe managing their physical and mental health. And I think Tetyana will probably talk about this at some point as well. But the key problem, I think, in the public mind and in public health policy to date has been that all the focus on diet has been on body size and body weight and obesity, et cetera, et cetera. And that's stigmatising, but it also means that people kind of give up because it's very, very hard to change your body weight substantially. And so this knowledge that actually what you eat might relate to your mental and brain health, actually from the research evidence seems to prompt more behaviour change. So that's really very positive. So what we have is a very comprehensive body of evidence now across the globe that links the quality of people's diets to their risk of developing depression. Now, there's several meta-analyses in the field. When we talk about diet quality, we're talking about things like a higher intake of plant foods, vegetables, fruits, whole grain cereals, legumes, nuts, seeds, these sorts of things. But of course, also very importantly, a reduced intake of what we call discretionary foods and ultra-processed foods. And when we look right across the world, we see that whether it's, Norway or Japan or the United States or anywhere else, that people who have a healthier diet are roughly 30-35% less likely to develop depression. This is prospective data. Now, really key, this is not explained by socioeconomic status. It's not explained by body weight, and it's not explained by other health behaviours like physical activity, smoking, etc. And it isn't apparently explained by reverse causality. So this is people eating differently because of their mental health symptoms, which of course does happen, but actually when you look at the data, people with certainly common mental disorders like depression, their diets are not vastly worse at all than the general public, and that's because the general public's diet is pretty woeful. So not only do we see this right across the world in many, many, many large studies, but we also see this across the life course, and this is critical. So right from the very start of life, what mothers eat during pregnancy is related to children's emotional and cognitive and neurodevelopmental outcomes. What kids eat in the first few years is important. Adolescence, which is a key time of risk for young people for common mental disorders. The quality of their diets is linked in a dose-response manner to their mental health, regardless of socioeconomic status of the family, things like family conflict, poor family management, all of these other factors. And then right at the end of life too, we see people who might develop depression later in life. If their diet is healthier, they have a reduced risk. And we also know, of course, that healthier diets are related to a reduced risk of developing dementia. This is really important because when we think about the determinants of mental health, they're very often things that we can't readily change, the risk factors. So they're things like, your genetics, early life stress and trauma, poverty, disadvantage, these types of things. These are really hard for people to change, whereas what they eat and their lifestyle behaviours are something that they have control over. And our research evidence suggests that they actually, this gives people a very powerful incentive to change their behaviour. So the work that we've done has influenced a lot of policy around the world. So it's reflected in more than 100 very high-level policy documents. The World Health Organization mental health report last year listed unhealthy diet as a risk factor for mental disorders. But in Australia, we also have had seen a big change in the clinical guidelines. So the Royal Australian New Zealand College of Psychiatry, their updated clinical guidelines for the treatment of mood disorders now places what is essentially lifestyle medicine as the foundation of treatment. And they call it foundational, they call it non-negotiable. Now, of course, there's a sort of a gap there because most clinicians get very little training in nutrition throughout their qualifications. And this is something that Tetyana will talk about. But what we also know is that current approaches to the treatment of mood disorders are insufficient. They don't address all of the burden. And then, of course, we have a massive issue with the mental health workforce with not enough psychologists, psychiatrists available. So the fact that we now have clinical trial evidence to show that changing people's diets, helping them to change their diets, is not only highly efficacious in improving depression, even severe major depressive disorder within a very short time frame, but it's also highly cost effective. And here we're not talking about expensive diets, we're talking about basic things, frozen vegetables, tin dried legumes, these sorts of things. And so this is a really powerful bit of understanding. We've got 4 clinical trials now that have tackled depression using a dietary intervention, dietary support, and 2 of those have done it in people with moderate to severe clinical depression. This is including a recent one, the AMEND trial that was done in young men, which is a very difficult population to support. They are not often help seeking, and they also quite resistant to dietary advice. But what we saw is when their understanding that this might influence their mental health prompted very pronounced dietary changes. So I'm going to go briefly through our SMILES trial because this is the one that we led. It was the first randomized control trial to show that you could take a dietary approach to treating depression. And in the SMILES trial, we randomly assigned people with moderate to severe major depressive disorder. So many of these people have been sick for many, many years. Most were on other forms. They were assigned to receive either dietary support from a clinical dietitian or social support from a befriending professional, which is basically something that we know is very helpful for people with depression, but is also commonly used as a control condition in psychotherapy trials. And over the course of 3 months, they were supported to change their diet. And what we saw was a very pronounced influence on their mental health with a very large effect size, such that a good 30% of them went on to have a full clinical remission of their major depressive disorder. Now, we've also done a big meta-analysis that's looked at trials where they've done a dietary intervention and they happen to have measured depression or anxiety as an outcome, but they weren't specifically in populations with depression. And from that meta-analysis led by Joe Firth, who's I think speaking later on, we see that this is effective in improving people's depressive symptoms. The trials that are available in major depression or depression have focused on a Mediterranean style diet. And Tetyana will talk through that a little bit more. But it's important to say that any dietary style or approach that increases plant foods, fibre, healthy fats, healthy proteins, and reduces discretionary foods appears to be very helpful. So I'm going to pass over to Tetyana now, who will talk about the implementation in practice and a bit more sort of detail about how you might put this into practice. So thanks very much.
Thank you very much, Felice, and thank you for having me here. So as Felice mentioned, in the next few minutes, I will continue discussing nutritional psychiatry with a focus on implementation. So I'll talk about what healthy diet actually means when we talk about healthy diet or better way of eating, what does it mean in practice, and also discuss the ways of talking about changing diet with consumers or thinking about changing our own diet. How can we do that in a more supportive and beneficial way? And I also mentioned a couple of opportunities for continuing education in nutritional psychiatry. So first, let's have a closer look at the diet which was used in the SMILES trial. So Felice introduced the trial as the first randomized controlled trial which actually used diet to improve mental health outcomes. So, and the diet used in the SMILES trial was designed by a fantastic mental health dietitian, Dr. Rochelle Opie, and based on combination of the traditional Mediterranean diet, which was adapted for Australian context with Australian guidelines for healthy eating. And this adaptation is quite important aspect because, as Felice mentioned, there's no one set healthy way of eating. There's various ways we can support our mental and physical health through food. So any dietary style with common denominators such as high consumption of wholesome, nutritious foods, whole grains, vegetables, fruit, seeds, nuts, with good fats, with good proteins, and with a low consumption of discretionary food, which often have a lot of added sugar, salt, fat, quite often ultra-processed, all the stuff which we don't really need in our bodies. But the SMILES trial used combination of Mediterranean and Australian guidelines for healthy eating. The main principles in delivery of the SMILES dietary intervention use some of the most effective methods for supporting food-related behavior change. So as mentioned before, it was designed by a dietitian. It was also delivered by dietitians. And we know research continuously showing us that when we have dietary interventions which are led by accredited professionals, they are deliver more support because dietitians such as myself and many other accredited professionals, they call sometimes nutritionists, sometimes nutritional scientists in other parts of the world. So we do have a knowledge to understand and to get into equation all these facts which may impact what and why people eating. Because we do understand that we need to base our recommendations on nutritional knowledge, on specific environment and societal factors which surround our consumers. To be effective in recommendations, we do need to take all this on board to be able to support consumers in creating change through the small, sustainable steps. To be able to use motivation, to be able to apply what we know, what coming to us from research in specific life situation. Going back to the diet and the food groups which were used in the SMILES trial. No, this is not working. Sorry about that. Few technical difficulties. Keep clicking, but nothing is happening.
Very sorry about this.
Yes, sorry about that. I think it's happening now. Yes, excellent. Thank you. So let's have a closer look at the specific food groups which were recommended in the SMILES trial. And when you look at this, I think you would agree with common belief that in general, Mediterranean style diet is quite possible. I don't want to say easy, but quite possible to follow because it's not about restriction. It offers abundance of choice in food. There's wholesome and nutritious food such as whole grains, as I mentioned before, vegetables and fruit and nuts and legumes with plenty of olive oil to increase satiety, with plenty of high quality proteins. And the only restrictive recommendations in the SMILES trial were around so-called discretionary foods. So right on top there, the little triangle. Only restrictions were here. And although the SMILES trial, as all successful trials, was not about restriction, but about inclusion of variety of food, the resources the trial provided to participants supported that idea that healthy diet does not need to be complicated. Believe me when I tell you we never ask and never will ask anyone to kind of whip up a 42 ingredient ragu to remain healthy. It's not about that. This example shows a few simple ways of combining common available ingredients to create reasonable and diverse meals. And that's what healthy eating is about. Common, wholesome ingredients, diverse meals, which we consume most of the time. So if you'd like any further information about the SMILES trial itself or about the diet which was developed for the trial, this is a couple sources for you to follow. So talking about changing our diet or supporting someone who wishes to do so is often about, it's often less about what and more about how. We kind of all know what we should be eating or maybe should be eating, but how do we discuss this in practice? How do we actually talk about diet when whole topic of diet been surrounded by stigma for so long, when even word diet creates so many negative emotions for so many people? When we have such a low knowledge in health professionals because they were simply not trained, not taught diet and nutrition. And when we have so much misleading and negative information about food and nutrition, something which should be so empowering and available for all of us. It's not an easy conversation to have, so in general, we do recommend to pick your time wisely and carefully, although we know that early interventions work, not for everyone. So be choosy with your timing. It is everything, definitely, in intervention. When you do talk about diet to consumers or to someone inside of you, make sure that you make that person an absolute center of attention, because we do need to listen and to understand what impacts somebody's way of eating, what challenges they might have, how we can support them. We do need to be able to create these small steps in long road of better eating. We do need to be able to acknowledge immediate needs in these small steps and these small goals. We also need to consider core values that people have, so recommendations we provide will actually fit with their situation and with their understanding of the world and healthy diet. We do need to be able to empower people and to become almost cheerleaders who themselves believe that change is possible. we do need to be able to address many barriers. We have, very unsupportive food environment. We have low knowledge. We have low skills, low resources, sometimes low monetary kind of resources available to consumers. So we need to be able to discuss this and to address this to be successful in our dietary changes. And we also need to commit to long-term approach. That's why I like to say that it's not ever goodbye, it's always see you later. So health professionals do need quite a few skills and abilities to be able to implement nutritional psychiatry in practice. And because of that, we have designed, as Felice mentioned, a continuing professional development for anyone who would like to implement nutritional psychiatry in their practice. It's been endorsed by the Royal Australian New Zealand College of Psychiatry. It's online. It's available right now. It is behind paywall because we use the money basically made by this course to support my work because my work is not supported by my university. So it gives you 20 hours of learning and it is available right now. We also have a free of charge accessible course on food and mood, which is more suitable perhaps for consumers or someone without previous health education. It does have enrollees from all over the world, well over 80,000, and we have a lot of fun discussing anything to do with food and mood. So both courses are available right now. I'm chairing both of these, and I hope to see you in the courses in the near future. Thank you very much. And sorry about all the difficulties.